So this is a recent article from the Des Moines Register, and the reason Dr. Nish is coming on the podcast today on the live line, and hopefully he'll be back on here in about a minute or so. It reads, Rachel Fratsky led her Mercy, Iowa City nursing staff in a mediation session to start the workday on a recent morning. A nurse manager, she had the nurses do deep breathing exercises, meditation, and thinking about when they first wanted to be a nurse or how they felt about passing their certifying board exams. The session was necessary, Fratsky said, to deal with the facts of COVID-19 and the rippling effects the coronavirus is sending through the nurses' workday, but also home life. Burnout is not going away anytime soon. The pandemic is not going to go away anytime soon, Fratsky said. The reality has made healthcare workers and administrators weary, thinking that the 2 years they spent warning people about the high contagious COVID-19 and its effect on hospital resources have yielded little to help relieve the pressure. Now, this is what Dr. Nish was talking about. Numbers at Iowa's hospitals remain high when compared with what they were in summer 2021. In all, 998 patients with COVID-19 as a primary or secondary diagnosis, including 215 admitted in the past 24 hours, and 174 in intensive care were in Iowa hospital beds on Thursday. And that was on January 13th. And that was according to the Iowa Department of Public Health. The number was 57 on June 20th, 2021, before the Delta and Omicron variants spread. So, Doc, this is what you were talking about just before we ran into difficulty here was the really high number of patients, the fact that they're all Omicron, but the startling thing in this slide is the difference between now and this past summer.
Yeah. So, we've gotten this messaging that the Omicron variant is less severe disease.
Yeah.
And that appears to be true, although that's not written in stone by any stretch of the imagination. The problem is it's so much more infectious. So many people are getting Omicron. And, it goes back to, and I know, we talked about this earlier. Oh, we wanted to talk about, the treatments. Well, let's not talk about the treatments. Let's talk about the prevention. We're stuck in our model in this country of, oh, I don't care if I get a disease because we have a treatment for it. Well, we don't have a treatment for most diseases. I just gave a talk to the Iowa Organic Association last week. And when you look at non-communicable chronic disease, such as diabetes, heart disease, cancer, autoimmune disease, psychiatric diseases, Alzheimer's, there's not a drug that we give that cures any of those diseases. The cure is the prevention. And it really is the same to me for communicable diseases such as Omicron. There are great ways to mitigate this disease. And the two biggest ways are, number one, get vaccinated. The statistics are startling. So a paper that just came out of New York, it said that if you are vaccinated, fully vaccinated with a booster or third vaccine, as we like to say, you are 7 times less likely to get the disease. If you're vaccinated with the third dose, you are 12 times less likely to be in the hospital. Now, just startling statistics. If you are out in public, wear a mask. We know masks work. We know masks prevent spread of the disease. So we have these really great preventative measures, yet we're tired of COVID. It's just like everybody's going to get infected, so let's just go for it. And that just really isn't the case. I'm going to tell a little story here. I have a friend, and we'll just call him Jim. And Jim, we discussed this ad nauseum last summer. He didn't want to get the vaccine. He wasn't sure of the efficacy of the vaccine. He wasn't sure of the long-term side effects of the vaccine. He's a little older than I am, mid-60s. He considers himself healthy. He eats a healthy diet. He moves and exercises. He's taking high-dose vitamin C, which I will tell you is not really effective because you can only absorb so much vitamin C a day. takes vitamin D, takes zinc, takes selenium, all these other things, and he's going to be okay. So I get a call from him almost 2 weeks ago, and goes, I tested positive for COVID. Oh, okay. How are you doing? Well, I got a little stuffy nose, but otherwise not too bad. 6 days later, how are you doing, Tim? Well, I'm not doing so well. I'm not feeling good. I've got a fever. I've got body aches. I've got chills. I got a terrible headache. 2 days after that, 8 days into the infection, Tim can't breathe.
Wow.
Tim's significant other calls me up, and Tim just fell, passed out. Call an ambulance. Tim spent a week in the hospital. Last question I got from Tim is, how soon can I get the vaccine? Too little, too late. But I asked Tim, I said, I want you to use this as an example to all of your friends who are unvaccinated as to why vaccines are so important. Had Tim been vaccinated and with the third dose, he might have had a mildly symptomatic infection. He would not, in all likelihood, have ended up in the hospital. And so the message here is get vaccinated and take appropriate public health measures. Wear a mask when you're out in public. Now, we can talk about, all the treatments for COVID, but here's the problem. Number one, our monoclonal antibodies that work for the Delta and the Alpha variant, 4 of the 5 don't work for the Omicron variant. Okay, they're in short supply. So if you think you're going to get a monoclonal, probably not, because they have to be administered relatively early in the course of the infection. And then, of course, Pfizer and Merck got approval for these antivirals. Paxlovid is the Pfizer one, which appears to be more effective. The problem with that is it's in short supply, and you've got to really give that within 5 days of the onset of symptoms. So it's not really at this point a widespread viable treatment. So we're stuck with the same things we've always used, remdesivir, but you got to, again, give that early in the course. It's an intravenous infusion, so it's not something you can take a pill for. And its efficacy is debatable. Then we talk about the other one, and you've brought this up this morning, ivermectin.
Yeah.
There was a recent study in the Journal of the American Medical Association that looked at the cost of ivermectin and what insurance companies paid out, and it's about $129 million for a drug that's been shown to be absolutely worthless for COVID. Yet we in our imagination, in our world of alternate reality world of quote facts, ivermectin is a treatment of choice, and we're spending millions of dollars on it. So it's a mess. But I think the message from every public health official, every physician who deals with this is get vaccinated. Because if you get vaccinated, yes, you might get Omicron, but it's going to be a mild disease, okay? Sore throat, scratchy throat, stuffy nose, headache, maybe some myalgias, body aches, but you're in all likelihood not going to end up in the hospital.
Before we move off of that ivermectin thing, I just got to say a couple of things about that. To me, it's ironic that people would take a medicine like that voluntarily and they would never get the vaccine. They're scared to death of the vaccine. They'll go take ivermectin. And what a revealing news story that was, because a lot of people seized on the opportunity to ivermectin. They would say that the guys that somebody won a Nobel Prize for ivermectin in humans. Well, yeah, but not for anything to do with COVID. It's used to kill some kind of a pestilence that comes out of rivers someplace. I think it's used in a lot of third world countries, never for COVID. And the dosage that you would use of that thing, nobody knows about. And yet it appears to be, kind of a go-to drug for some people. They want to go grab this ivermectin stuff. It's just shocking to me that people would do that and not get a vaccine when there's millions of people walking around like you and I that have had the vaccine that are perfectly healthy. And a lot of people have taken ivermectin and not fared well because, again, it isn't meant for this application. They don't know how to dose it. They don't know how to use it. And what a disaster. Well, one thing I wanted to ask you about with this surge now, there are horror stories starting to circulate that people are wanting to go to emergency rooms for kind of traditional emergency room maladies, and they're not able to get the immediate treatment. And remember now, this is an emergency room. That's the idea. That's the reason you go there. You're supposed to be seen immediately, but they can't because of the overwhelming of the ERs with these COVID patients. I guess the first question is that just a horror story, or is that real? And is it real here in our part of the world?
It's real. It's real in Des Moines, Iowa. It's real throughout most of the United States. And frankly, it's real throughout most of the world. And, it's multifactorial. So, we have more people coming to the emergency room with symptoms of COVID. The real bottleneck, though, is we have hospitals that are full. We can't move people out fast enough to move people out of the ER into those beds. We have critical shortages of all workers in the hospital. So, we think of doctor shortages, we think of nursing shortages, but who cleans the room? Who gets the room ready for the next patient?
Yes.
Housekeeping, environmental resources. We have shortages of those. So that's this huge domino effect of how do we turn patients out, turn rooms over. And it takes more than a nurse and a doctor. It takes an extraordinary amount of people. And so what's happening with Omicron? So Omicron spreads much more rapidly than Delta. It's 2 to 4 times more transmissible, and more people are coming up with symptoms. Well, if you have symptoms, you've got to stay home and isolate for 5 days, right? So now, not only do we have an innate shortage of healthcare workers, we have this exacerbated by the fact that people are getting symptoms more often and have to stay home. So now we have so many people out of work, and that exacerbates the whole problem. The other thing is, if you look at statistics since February of 2020, we have lost 450,000 healthcare workers out of the system. Retirement, just giving up and saying, I'm done with this, whatever it might be. And so we have this perfect storm of losing healthcare workers, overwhelming the system with the number of patients, having healthcare workers out because of symptomatic illness, and it's a mess. And you wonder why you sit in the ER. I'll give you another story. My cousin who is in Savannah, Georgia. Okay, Savannah, Georgia, Des Moines, Iowa. You can interchange them, frankly, as far as this story is concerned. His wife has a serious illness. They had to go to the ER. They spent over 30 hours in the ER. She had to be admitted to the hospital. There were no beds. So it's overwhelming our systems. We're having to cancel elective surgery cases again. That's been going on for weeks now. And it's just, and I think, and I'll talk about this at the end of the podcast, but, when we first started this crisis, the email today was, oh, we don't have enough PPE, or nope, we don't have enough of this or enough of that. Now it's, we don't have enough beds. And I think that healthcare workers are losing a little bit of hope. We're in short supply of hope. And we'll talk about it at the end, because I think they look at the general public and wonder, what the hell are you thinking? Get your damn vaccine. Why are you having parties? We are still under crisis here. And, we had a tumor board last week, and part of our tumor board is we have a physician from the University of Nebraska. And that morning, he got an email that they were entering crisis mode at the University of Nebraska. What does crisis mode mean? Crisis mode means we are in a crisis here, and we're short workers, we're short hospital beds. And when you do that, you can't achieve the quality of care that people are used to. We're not getting as many nurses nurses are being overwhelmed with too many nurses, too many patients per nurse trying to take care of them. We can't take care of people the way we're used to in this country. And it is a crisis.
Yeah. And, you and I have talked a lot about the social distancing element. You mentioned some of that. We've also talked a lot about masks. And I'm hearing that people now, because of the transmissibility of this Omicron thing, they're saying, don't use that Mickey Mouse cloth mask that you were trying to get by with. You got to go to a K95 or a N95 or something like. Yeah, what's that all about?
Yeah, well, the current you look at a cloth mask and you look at the way people wear them and you look at how thin they are and you kind of laugh a little bit. I kid people, they'll have that thing down below their nose and I say, oh, nice chin mask you have there. So yes, we really, really have to switch our thought on masks. So single layer cloth masks really aren't very effective. And we truly need to go to either NK95, and those are the masks made in China. The problem with those are there's a lot of counterfeit masks on the market, so you don't know without doing a little research what's good, what's bad. There are plenty of N95s available now. So I just ordered last week 5 N95s. I have to travel later this week, and I'm wearing an N95. So we really need to be going to the higher filtering masks. And so those, like an N95 is 4 layers. It has an electrostatic layer that traps these virus particles. If you're going to wear a cloth mask, use a multi-layered cloth mask, potentially with 2 cotton layers and maybe a polyester or a silk layer in between. Those are better because you not only get the mechanical filtration, but there you get the electrostatic filtration with the polyester and the silk. But the N95 and the KN95s are what we should really be striving for. The other thing is they need to fit really well. Okay?
Yes.
They can't just dangle off your face. They need to be tight across your nose, tight across your cheeks and chin, and not have these big gaping openings.
Doc, I'm a hockey guy, and they had the outdoor game here recently up in Minneapolis. It was below zero during the game, and I saw the most graphic illustration of the transmission of COVID that I've ever seen before. It was during a hockey game. The players coming back to the bench would sit there huffing and puffing after their shift, and the steam from their breath, every vapor, every droplet was frozen, of course, because it was below zero, and you could see it rising up. These guys look like a human steam engine sitting on the bench. And the interesting thing about it was the coaches stand on a riser behind the players' benches, and the coaches are probably the worst wearers of masks that I've ever seen. Now, they're required to do it by the NHL, but I mean, these guys will do anything but wear one properly. They wear it below their nose all the time. Every time they want to say something, they pull it off. And I've often thought, my God, no wonder you guys are having these issues with having to shut down the league because of COVID. But they're standing right above these players as they come back. And the players are being rotated out of lineups regularly still because they're testing positive for COVID. They think a lot of that transmission is actually taking place during the game. Well, they're spreading it to the coaches like human chimneys during a hockey game. But man, it also showed the volume of air being expelled by these players. It's just amazing. It's not a small thing. I mean, the human breath coming out of a body is a billow.
Mm-hmm. Yeah, and it's, we think, oh, well, that breath only travels a few inches. No, it travels feet. It's this big cloud.
Yes, exactly. Well, we had a little difficulty here coming on this morning, so I got my slides out of order here a little bit, but I wanted to bring this up. This was an article here in the USA Today, and Doc hit on this 800,000 new cases daily. This was over the past weekend. About 158,500 Americans were reported hospitalized on Saturday. Hospitals in 46 states report rising numbers of patients. 34 states report rising death rates. Now, that's interesting because a lot of people believe, oh, Omicron's just a cold. You're just going to get it. You're going to get over it. But no, there are people not getting over it, folks.
Omicron, you know what?
Yeah.
Omicron is a dangerous virus. And this is the messaging that's got to change because people are getting the idea, oh, it's nothing but a cold. It might be nothing more than a cold in people who have had 3 doses of an mRNA vaccine. In people who have not been vaccinated, it's a deadly virus.
Okay. Good point. Well, I wanted to show this one highlighted portion here that I had that interested me at the time. It says, in the Omicron-driven wave, severe COVID-19 outcomes were reduced mostly due to protection covered by prior infection and/or vaccination. But intrinsically reduced virulence may account for an approximately 25% reduced risk of severe hospitalization or death compared to Delta. It said, I don't know, Doc. I mean, what are we talking about here? Yeah.
I don't think we know that right now. And I think that, it's, again, when you look at who's hospitalized and who's dying, it's the unvaccinated.
Yeah.
So that may be true in the vaccinated population. You know, I was listening to Mike Osterholm. He does a weekly podcast and talking about other countries where this is a little bit ahead of our curve. They've seen, you know, this dramatic spike in cases. The cases have come down quite dramatically. And the other thing they saw is that they weren't seeing the parallel spike in hospitalizations and parallel spikes in death. They were seeing less hospitalization per, you know, 1,000 cases, and they were seeing less deaths. Right now, we're not seeing that as much in the United States. We're seeing, you know, more of a parallel rise in hospitalization and parallel rise in deaths. And is that due to, you know, something different about the virus? Is it due to the fact that, you know, we don't have as high a vaccination rate as some countries? Is it due to our underlying ill health in this country? Obesity, high blood pressure, diabetes, cancer, autoimmune diseases. You know, I've said this before, we're a very sick country. It's estimated that 88% of us are metabolically abnormal. So if you're metabolically abnormal, you're at higher risk for complications from any viral illness, let alone COVID.
Do you think that applies to the long haul syndromes as well? Are those people more prone to long haul syndromes?
We don't know that. You know, we've seen a lot of long haul in younger people, and that's a question I don't know the answer to, and I don't think we know the answer to. All right, well, certainly in the acute phase, we know that if you have obesity and diabetes, your chance of doing poorly are much higher than if you are metabolically normal.
Yeah, roger that. Well, let me bring this up. We're getting some questions here on the live stream. This is from Mary Knox. She says, she would like to know if Dr. Nish has read the study about compounds extracted from hemp being able to prevent infection from entering human cells. I read about that. I'm certain more studies are needed, but is there some hope that cannabis compounds can be used for treatment? And have you looked into that study at all, Doc? Did you read about that?
I know nothing about it, so I can't answer that question. I've not seen that in the, you know, major peer-reviewed literature, and so I haven't looked into that.
Oh, well, here's the second part to this question. I know it came out of Oregon. It says, according to the Oregon study, the pair of cannabinoid acids that bind to the SARS-CoV-2 spike protein are cannabis, I can't read that, or CBGA. And so also the spike protein is the same drug target used in COVID-19 vaccines and antibody therapy. Well, it's promising. I think even the people up in Oregon, was at the Oregon University, I think someplace where they did this research, would say that it's too early to know for sure. It hasn't been peer reviewed and all of those types of things. But, you know, people that are proponents of hemp and proponents of cannabis, they're always hopeful that it can be legalized so that people can benefit from what appears to be good stuff that comes from this weed. So, and I know in the cancer field that cannabis is often talked about, Doc.
Well, it is, but here's the problem with cannabis. The marketing is way out front of the science. Okay. And the science has been hard to do because cannabis, whether it's just CBD or whether it includes THC, is still illegal at a federal level. So it's really hard to do research on it. And, you know, the question for this is, and I don't know this study, was it a bench study? Was it a patient study? Because what looks good in the Petri dish many, many times turns out not to be effective in the human body. So I think, you know, having not read that, but we're probably still a long way from, you know, recommending cannabis, I'm sure. But again, you know, we have something that's highly effective. It's called a vaccine.
Yeah, that's
highly effective with very, very few side effects. And, you know, we hear about side effects. We hear about myocarditis and pericarditis in younger adult males. The side effect profile for the average adult over 40 years old is extraordinarily safe.
Now, here's a question that I had, and I've saw this again in news articles, not so much here locally, but out around the country. And it was that people were testing positive with home kits and at test sites that are opening up again because of Omicron. And they're running down to the ER immediately and kind of flooding the units down there. And they probably could, well, certainly could just as well be at home, at least initially, before coming down to the ER and taking up space down there. Is that an issue here locally?
You know, I have no idea. I haven't tested that theory. But, you know, so you test positive. There's reasons to go to the ER. That's why it's called an emergency room.
Yeah.
So if you are short of breath and you can't get your breath, and a lot of people now have these pulse oxes at home, and your pulse ox starts dropping below 90, that's a reason to go to the ER. If you're having, delirium and you can't focus and you can't function and you're falling, that's a reason to go to the ER. A positive COVID test, a stuffy nose, a sore throat, that is not a reason to go to the ER. So people have to use the ER is for emergencies. Now, if you think that you are getting worse and you're feeling worse, you're not at the point where you're gasping for oxygen or air, and you're not at the point where you're delirious and you feel that things are not going well, go to an urgent care center, okay? Stay out of the ER as long as possible, because we have lots of urgent care centers, they're dealing with this every day. But you do not need, if you're mildly symptomatic and have a positive COVID test, there's absolutely no reason to go to the ER.
Well, this next story is kind of local here. I wanted to bring this up. Not so much to get the doc's reaction, but just kind of it's newsworthy here from the Des Moines Register. This Tony Lays, this guy does great work. I've seen a lot of his writing recently. Polk County is setting up drive-through COVID testing sites to help Central Iowans determine if they've been infected by coronavirus, as cases once again swell thanks to the highly contagious Omicron variant. The first such site was scheduled to open today in the parking lot of the county's River Place Center. That's on Des Moines' north side at 2309 Euclid Avenue. The site is to be open from 8 a.m. to 6 p.m. every day. It should be open today, folks, including weekends. County officials said in a news release Friday. Most sites are to be announced, more sites to be announced soon. PCR and rapid tests will be made available for free to people who have COVID symptoms or who have been exposed to someone who is infected with the coronavirus, the county said. But participants are asked to bring health insurance cards if they have coverage, and to bring identification. I don't know if they're suspecting or thinking that, people might abuse the situation and take more free tests than they're eligible for. I don't know. I kind of sour when I look at stuff like that, Doc, because I'm an old lefty and I cite this circumstance all the time. There's this F-35 fighter jet that's been mothballed, basically, that costs $1.75 trillion and has basically never left the ground. Even the people in the military say that it's worthless. $1 trillion is a stack of $1,000 bills 67 miles high. And one of those planes costs $1.75 trillion. And I look at this and think, oh, what the hell? I mean, you got to go down there and prove that you're destitute to get one of these things. And then you got to have an insurance card. What for? I mean, I don't know. I just think that's weird. But I'm sure that you would agree that any testing that anybody can get's a good thing.
Well, no, I don't agree with that. Actually.
Oh, okay. All right, good.
So I think if you're symptomatic, absolutely, you got to get a test. Do I have COVID or don't I? Let's define exposure, though. Yeah. So, casually passing by someone on the street who has COVID is not an exposure. An exposure is defined as greater than 15 minutes interacting with a person within 6 feet who tests positive for COVID. Mm-hmm. That's an exposure. So, but you have to remember, what's the timing after exposure that you should be getting a test? It's not 24 hours. Do not get a test within 24 hours after an exposure, because there's a short incubation period. It's actually shorter for Omicron, 2 to 3 days. So we should be getting tested for a true exposure 3 to 5 days after the exposure, not immediately. The other thing, and this came up in one of Mike Osterholm's podcasts, is a woman was testing herself weekly. Even though she had no symptoms and no exposure, she was testing herself weekly. And, Mike, and I know there's very different opinions about this. There's a guy at Harvard thinks we all ought to be testing ourselves every day before we walk out the door. Mike Osterholm is very different in that. He says, if you're have not been exposed and you're not symptomatic, don't go run and get a test, because the tests are, they're a resource and they're a valuable resource, and we shouldn't just be using them up. So testing is not for everyone. We have to use our tests judiciously. And as Mike says, it's a snapshot in time. It's one snapshot in time. The other problem we have with tests are, particularly the antigen, both the PCR and the antigen tests are, If I have a positive test, does that mean I'm infected, or does that mean I'm infective? Meaning, am I still spewing the virus? And so with a PCR test, you can have a positive PCR test weeks after being infective, meaning you're spewing the virus. So we're still trying to figure out the actual interpretation of the tests. So it's not as straightforward as people think. We've not done a good job at collecting data and comparing the rapid antigen tests with the PCR tests. I think the bottom line is, if you have symptoms and you test positive, whether it's a PCR or a rapid antigen test, you have COVID.
Well, here's a question, and you may have addressed this a little bit about these PCR tests, about the home testing. Susan wants to know, how many days after exposure should you use a rapid test at home? Okay, so
3
let's
to
say you've
5.
been exposed, somebody in your own household, somebody that you're very close to, and they've got COVID. Should you test right away? And will it tell you anything if you test right away?
Do not test right away. A negative test is meaningless in that case. I would wait probably 5 days. So if you were exposed, there's going to be a 2 to 3 day incubation period. Once you become infected, even before symptoms, you could start secreting the virus. So I would say 5 days, that's when you should test.
Here's one. I love Mary Knox. She says, aren't rapid tests that are being made available less accurate? It is my understanding that there are many false positives. And is it the fault of the test, or is it the fault of the testee? Tester, I
So
guess.
there's more false negatives. False negative is more prevalent than false positives. And they are all over the board. I mean, you'll find studies where there's 50% false positives. There's 13% false positives. So this is a difficult, and the tests vary. So there's some tests that are better than others. It depends on when you're taking the test. So again, if you're exposed and you're taking a test within 24 hours, that's not an appropriate way to test. Got to wait about 5 days. So it's all over the board. The bottom line is, if you're symptomatic and you do a rapid test and it's negative, you should probably go on to a PCR test.
No.
If you have a rapid antigen test that's positive and you're symptomatic, I think you have to believe that test.
Okay, great. Well, as the doc mentioned here at the beginning, he's got some things that he wants to say at the end of the show. I've got some things here that I want to show, and I want to bring this up on the screen here, and the doc can talk about this as we work through this too. And this was an outstanding, I guess you could call it a photo essay. Again, that came out of the Des Moines Register, but it was really great. And they followed these respiratory therapists on the COVID-19 front lines. And we can just go through these. I'm not going to be able to read it. It doesn't look like
I want to say something, George, before you go through these. I want people not to just look at these. I want you to feel these people. Look at their expressions. And what feeling does that generate in you?
Yes.
Because it's easy to look at the pictures and say, oh, yeah, it's a picture of this person or that person. But look at their eyes. Look at their expression. Look at the sadness in their faces.
Okay, good. This the nurse that they followed quite a bit here, and they're a picture is worth 1,000 words. This is Mira that they're showing here, and this is part of the regimen. I mean, this is after she was in a room with someone. This is what she's got to do when she comes out to get herself prepared and ready to work with the next patient. And this is just a little bit, to my mind, of how arduous this is, all day, every day, doing this type of cleanup and prep. Here is Mira on the left, resting her head on the shoulder of Sydney during a brief moment of respite in the critical care unit floor at Unity Point. And again, like the doc says, I mean, just look at that picture. Again, the point that I make is every day, all day, long shifts, short-staffed, helping people sometimes that literally refuse to help themselves. And they're down there doing this. Now, this is a very compelling and interesting photo. This is, and again, it's difficult for me to read the type because it's so small down there. But as I understand it, this is a young man that was expected not to make it. I mean, he had the most full-blown bad symptoms that you can possibly have. And they think now that he's going to make it. And there's Mira literally wiping tears from her eyes. And you can see the other nurses, they're looking in, peering at this individual because they did not think that this guy was going to make it. I mean, that just sends shivers, down my spine. Here's Mira a little bit, again, struggling with this apparatus. You can see I suppose that's a breathing hose or whatever coming out of the back of that thing. And again, okay, folks, you've heard all of these people bitch and whine and complain that they can't wear a mask, for a few minutes a day when they're in a social situation with other people. How'd you like to wear that every day, all day? Again, taking care of people, many of whom refuse to take care of themselves, and they're in these emergency rooms now. There's Mira again. Now she's and I've been in the ER. This is she's looking inside the glass enclosure there, the door from the outside looking in. Again, just the caring on the faces of these healthcare workers and these nurses is almost enough to make you tear up. Okay, so this is going to be the last slide. I grabbed this one and put it up because here she is now. This is a room that maybe fortunately is available. It's open. She's in there waiting for the next patient. And I look at that and it reminds me as a kid of these signs they used to put up on the side of the road where fatal accidents were. And they would be like a cross or something. And they would say, don't you be next. Well, that's what I think when I look at that. When I look at that photo, Mira's in there every day, all day, or someone like her, and they're waiting for you folks. So don't let it be you next, Doc.
Yeah, that scene plays out hundreds of times a day.
Yeah.
In the hospital. It's hard to watch people die. It's hard to watch people die and the numbers they're dying. And this is taking a toll on healthcare workers. And we don't even have any idea the future mental health ramifications of this. So, if you don't want to get a vaccine, you don't think you need it, think about these pictures. Think about what these people are doing day in and day out, because it's kind of devastating. If you feel tired, confused, or whiplashed, CDC's changing recommendations, you're not alone. Everybody's in this, okay? Everybody is feeling that right now, whether you're in healthcare or whether you're not. We're all tired of hearing the numbers. We're all tired of hearing what's going on. We feel sometimes, like I said, whiplashed from different recommendations. I think the CDC is trying to do the best they can with the information they have, and then also putting in that context of letting people live their lives in a somewhat normal way. I think one thing we're losing in healthcare, though, is hope. So Desmond Tutu has a great quote, and he defines hope as being able to see that there is light despite all of the darkness.
Yeah.
And we thought, this was going to last a year. And then, it's going into its second year. Now we're into its third year. And we're losing hope. I think we're losing hope for multiple reasons. And I think one of the big things is, as healthcare workers, we're losing hope because people are just not making good decisions. And it doesn't just affect them. It affects many, many people, not only around them, but the downstream effect of what's going on in healthcare. I mean, Mayo Clinic and all the hospitals in Minnesota took out full-page ads imploring people to get vaccinated and use social distancing. This is the Mayo Clinic. This is one of the most prestigious institutions in the entire world.
Wow.
And they are desperate. And so give people hope. We're not done with COVID. We're going to have to, what we're thinking now is the next 3 to 5 weeks, somewhere in there, the Omicron will probably peak and then we'll start to go down. So there is maybe light at the end of the tunnel based on the data that we're seeing from other countries. But I want people to, again, I don't want you to take away from this where there's no hope for this. There is hope. As I like to tell people, again, we hear so much vitriol on the internet and on the TV and hate, and it's Martin Luther King Day, right?
Yes.
He gave people hope. So I want to go back to the 10 words that one of the guys I really respect, James Dottie, he runs the Compassion Institute at Stanford. And I want people to think of these words every day. Number 1, C, compassion. Have compassion for the human race. Have compassion for yourself and everything on the earth. Number 2, dignity. Everyone deserves dignity. Doesn't come with skin color, doesn't come with sexual orientation, doesn't come with race. Every human, every living object deserves dignity and to be treated that way. Equanimity. Equanimity means calm in the face of chaos. We are in a chaotic situation, but bring calm. Yelling at each other doesn't bring anybody any good. F, forgiveness. It's really easy if someone comes into the hospital, and I see this when I talk to healthcare workers, why didn't they get vaccinated? You know what? We have to forgive those people. They have their own reasons. Yeah. I'm imploring people to get vaccinated. There's no excuse not to, but let's forgive one another for things that may not have been done appropriately. Gratitude. This is one we're losing right now, right? What should I be? There's nothing to be grateful for. Yes, there is. You woke up today and didn't have COVID. You woke up today feeling well. You woke up today able to care for your family and your kids. Have gratitude for those things that are good in your life. And we all have things that are good in our life. Humility. This is a really big one. Because as scientists, we're trying to predict certainty. Everybody wants certainty in their life, right? Well, even the scientists, even those who study this every day, 8 hours a day, are humbled by what's going on because we just don't understand the virus as well as we want to. So we all have to be humble, and we all have to live with this uncertainty, knowing we don't know exactly what's going to happen tomorrow. I is for integrity. And this is another one that we just don't have the integrity in our news anymore. We don't have integrity in how we communicate with one another.
Amen, brother.
And we need to have integrity. So as a person in the medical field who's talking to you, that is one of the things that's so important to me. I'm not going to, tell you wild things. I want to have integrity. K, this is something you can practice every day. Kindness. Kindness. I mean, I read about things, people beating the hell out of people on airplanes.
Yeah.
Be kind. You know what? We are all in this thing together, and we are all feeling the anxiety and the confusion. Be kind to one another, because kindness evokes chemicals in our body, dopamine, serotonin, oxytocin, that not only makes us feel better, but makes your fellow human feel better. Be kind. L, love. We need to demonstrate that we love one another, not in the romantic sense, but that we love our fellow selves and that we love ourselves. Demonstrate love every day in some little way.
Jesse Cullen Young, Doc, the young bloods, yeah.
But it just is, we've this society of hate and this society of misinformation is just, the integrity of news has just precipitously declined over time. And we know the good news sources, we know the crazy news sources, and we really need to have integrity in our scientific community and even amongst ourselves. So those are words I want to leave with people. But the big four are hope. There is hope. We'll get through this. Kindness. Be kind to one another. Be kind to one another. Show love and show care. And you know what the best way to show care to our healthcare workers is? Get a vaccination, wear your mask, and help them out.
Yeah. Help Mira out. Help those people out there that you saw there in the photos. Makes an old man weepy to hear some of that. But, I started off the podcast and we kind of got off to a flying stop because of the internet issues or the problem with Facebook. But I was explaining, Doc, that your modern history anyway is this mind body connection. And what you're talking about here are these mind things, which is huge. And it also has to do with medicine. It isn't just a doctor shoving pills at you. It's a doctor telling you things like this, inspiring you, mending your mind, so to speak, that has a lot to do with health and well-being.
You can live in a world of hate and conflict, or you can live in a world of love and compassion. It really is your choice. And I did forget one letter, J. Judgment.
Oh, sure.
We're constantly judging each other, right? So I judge someone because they didn't get a vaccine. Well, if I don't know the backstory, then maybe I shouldn't make that judgment. And I don't mean to judge people for not getting it. I'm just saying, you know what? The best way to treat COVID is prevent COVID. And we know that the vaccines do that. It's really interesting. I have a brother-in-law who's had some trouble in his life. And my dad always wondered, well, what's wrong with him? Why can't he get his life together? And I said to him, Dad, do you understand the backstory? And as a young child, he feared for his life for multiple reasons. My dad's like, oh, now I get it. So we make immediate judgments of people based on what they did do or what they didn't do, based on their skin color, based on the fact that they have tattoos or piercings, based on the fact that they're gay or straight. We make judgments all the time, yet we never know the backstory of that person. So we have no right to judge people. And we make too many judgments, good, bad, whatever. And so I want people to really look at what's going on and don't judge it as good or bad. It is what it is. We're here in the present moment with this. It will get better. But don't be so judgmental, because judgment leads to negative emotions.
God, I love it. That's great, Doc. I mean, you always wrap up the podcast by George live lines the best that they can. Anything else here in closing that I didn't ask or that you want to say? I mean, that's extremely well said,
You know what?
Doc.
That's my take-home message. I mean, we've got to be, just more compassionate and kind to one another, and accept where we are in life, and life will go on. Life will get better. And that's it.
Yeah, well, that's plenty. Folks, that's Dr. Andrew Nish. Dr. Nish, thanks again for coming on a podcast by George Liveline.
Thanks for having me, George, and I wish the best to all your audience.
That's great. We'll be back with him soon, folks, and I appreciate all the comments as well. Like I tell people, I mean, he's a really smart guy, but he's also a practicing medical doctor, and where else can you get together and talk with a guy like this except on a podcast by George Liveline? I just love it. And folks, if you like the show, if you want to get podcasts by George and you want to be notified, particularly when each new episode occurs, either on Facebook or YouTube or wherever you want to subscribe, go to podcastbygeorge.com and you'll be able to pick a platform there. There are little icons like the Facebook icon, YouTube, Apple Podcasts, places like that. It'll take you right there to the most recent podcast, and you'll also see where you can subscribe, follow, and like Podcast by George, and then you'll be notified each time a new show drops. But that's going to do it for today. That's going to wrap it up. That's all there is. And there ain't no more. That's another podcast by George.